Enabling objective 1C. So list and interpret critical clinical findings, including obtained height, weight, body mass index, and relevant family history. So in other words, if a child comes with hypertension, what physical exam will you do? What history will you take? That is what we are going to do for the next segment. Please, I need somebody to read this case for us right away.
Yeah. You are evaluating a 6-year-old girl. You notice and that the BP is 158.92 millimeter of mercury. She has had 4 similar readings. Which question will you inquire? And list 5.
Beautiful. Beautiful. So this question is basically saying, if you have a patient with hypertension, a pediatric patient, what questions will you ask? What historical questions will you ask? What historical questions will you ask? Number 1, is there a family history of hypertension? Because remember that we said that essential hypertension, family history is stronger. Secondary hypertension, family history is less likely. Which cause of secondary hypertension may have a family history? Please, who we learned it. Who can tell me?
Polycystic kidney disease.
Oh, beautiful, beautiful. You know, I like the way we are now drawing all the associations. So first, family history of hypertension. If you have a child, say 5 years, 4 years, 3 years, and there's a family history, all uncles have had hypertension and they had it when they were very young, it should then draw attention. Oh, could this child have polycystic kidney disease? Number 2, what are the previous blood pressure readings? Number 3, history of nocturnal hypertension. History of nocturnal hypertension, is it more likely in essential hypertension or secondary hypertension?
Secondary.
Secondary. History of urinary tract infection. Why? Because we are thinking about possible post-UTI glomerulonephritis. Maybe the person had some obstructive uropathy and then the kidney has been scarred. History of pyelonephritis. History of congenital kidney or urologic abnormalities. Doctors, please write all these things down. And don't forget that you're going to get a replay of the video as well. Perinatal procedures like umbilical artery catheterization. Please, umbilical artery catheterization, what condition goes with it? Hey,
Renal artery
thrombosis. Oh, now we are getting
renal artery thrombosis.
We are getting it. Beautiful. What about if the child is snoring, has daytime sleepiness, hyperactivity? What are you thinking about? Obstructive sleep apnea. Family history of polycystic kidney disease and medication history. Has the child been given any steroids, any stimulants, right? Maybe the child has ADHD and the child has been given an amphetamine or something. Ephedrine. Well, oral contraceptive pill, I will hold on, especially with a 6-year-old child. But if the child was 13, then I'll bring oral contraceptive pill first. So medication history, any recreational drugs, less likely in a 6-year-old child, more likely in a 16-year-old child, right? Anabolic steroids, stimulants like cocaine and amphetamine, more likely in a 16-year-old child, less likely in a 6-year-old child. So doctors, please, you must be able to recite the historical things you want to ask in any child who presents with hypertension. Family history of hypertension, previous blood pressure readings, history of nocturnal hypertension, history of urinary tract infections, pyelonephritis, history of congenital kidney disease or urologic abnormalities, perinatal procedures like umbilical artery catheterization, snoring, daytime somnolence, family history of polycystic kidney disease, and medication history. And the medication history, we've listed all the medications you should also learn in order to help you. If it's an adolescent female, please don't forget oral contraceptive pills. Okay, so physical exam findings for a pediatric patient with hypertension. Now we finish the historical features. Physical exam findings. I'm going to skip this and then I'll come back to this later. I want us to play this game. I want us to play the matching game. I want you to link if A goes with 1 or A goes with 2 or A goes with, so what I'm saying is that the conditions listed here as A, they don't go with these ones. So I want you to arrange them. So please, everybody. So if you type A and you think A goes with 1, type A1. If A goes with 2, type A2. Please, are you getting the whole I'm talking about? If A, so we've mixed up the condition with the features on the 1, 2, 3, 4, 5, 6, and we have the features. So renal parenchymal disease, what will it go with? Will it go with 1, 2, 3, 4, 5, or 6? Renal parenchymal disease.
5.
5. Okay, let me write it down. This is what the class is saying. They are saying A goes with 5. So A5. Yes. Okay. B, renal artery stenosis. What does it go with?
2. Renal grade. 2.
B. So you are saying B2. Okay. What about coarctation of the aorta? It goes with what?
3. Femoral palsy. 3.
Okay. So C3. Okay. What about Wilms tumor? It goes with what?
1.
So that is D1. Okay.
Yeah.
All right. What about hyperthyroidism?
6.
Tremors. That's 6. E6.
So E6. Okay. What about congenital adrenal hyperplasia?
F4.
Ambiguous genitalia.
F4. Okay. So your answers were A5, B2, C3, D1, E6, and F4. Let's see. A5, B2, C3, D1, E6, and F4. In other words, renal parenchymal disease goes with edema, right? Renal artery stenosis, if you listen over the kidneys, you may hear a bruit. Coarctation of the aorta. Oh, come on. I think somebody's microphone is on. Coarctation of the aorta. There will be diminished femoral pulses. Wilms tumor. There will be an abdominal mass. Hyperthyroidism. There will be tremors. And congenital adrenal hyperplasia. There will be ambiguous genitalia. Okay, good. So let's use this and go through this question. So you have a child who comes with either this rash or this lesion plus hypertension. What's your diagnosis? Or you see a child with
tuberous sclerosis.
Tuberous sclerosis.
Okay, tuberous sclerosis. So please learn that hypertension plus ash leaf spot. This is what we call the ash leaf spot. If you see the ash leaf spot or you see this, what we call it adenoma sebaceum, tuberous sclerosis. Okay, good. Next question. If a child has ambiguous genitalia plus hypertension, what diagnosis are you going to think about?
Congenital
adrenal hyperplasia.
Congenital adrenal hyperplasia. One thing I want you to remember is that excess endogenous secretion of androgens and mineralocorticoids is found in children with congenital adrenal hyperplasia, and mineralocorticoid excess may lead to hypokalemia. Congenital adrenal hyperplasia, hypokalemia, ambiguous genitalia, hypertension. So ambiguous genitalia plus hypertension plus hypokalemia. Think about CAH, congenital adrenal hyperplasia. Doctors, can I move on? Hello, please, can I move on?
Yes.
Please move on.
Beautiful.
Yes.
Okay, what about this? You see this kind of
Neurofibromatosis.
Neurofibroma.
beautiful. And what is the name of this kind of thing? We call it what?
Cafe
Scaphoid spots.
Cafe spot.
Cafolate.
So if you see a patient with cafe spots plus hypertension, your answer should be neurofibromatosis. Okay? Okay, good. So that was that.